going to use what you've learned thus far in the course from the assimilation node to improve thyroid hormone production? You're going to recall that food antigens are often triggers of an autoimmune response. So let's look at gluten and celiac disease, which you've now learned quite a bit about. Here's a study that showed the prevalence in celiac disease of thyroid dysfunction is probably threefold at least. What they did in this study was take patients who'd had their thyroid glands removed, and many of them had subclinical hypothyroidism. Sorry, they were celiac disease. And many of them had subclinical hypothyroidism. Many of them had autoimmune hypothyroidism. They'd never been on a gluten-free diet. When they put these patients on a gluten-free diet, the majority of them either no longer had subclinical hypothyroidism or normalized their autoimmune state to a euthyroid state. More recent publications seem to indicate it may be fourfold, not just threefold increased prevalence of thyroid dysfunction in celiac disease. And do not forget, your patients with celiac will have nutrient deficiencies because of their celiac. So you're almost always going to have to address thyroid nutrients in those patients. And you've learned quite a bit about non-celiac gluten sensitivity. We need more data and evidence about this, but we do know that the prevalence of thyroid dysfunction is higher in those individuals as well. Keep your pulse on that literature as we learn more about it. Toxins affecting thyroid function. How does this happen and what kinds of toxins? We know that fluoride will do this. Same column of the periodic table, right? Iodine, fluoride. So that is problematic. Fluoride is present in many herbicides and pesticides. It's a wonderful neurotoxin. And therefore, if our farming practices and animal husbandry and incorporate that, you're going to be eating that. More than 150 nutrients or toxins have function from industrial chemicals, heavy metals, cadmium and lead, and more than just cadmium and lead. So we're just giving you a sampling of the literature here. There are more hidden slides in your deck. But toxins do not only affect thyroid hormone production, they affect transport and conversion and sensitivity. Recall, too, that toxins can be a trigger of autoimmunity and thyroid autoimmunity. And then there are infections. How do infections perhaps cause decreased production of thyroid hormone? We probably need more data and evidence here. We have a lot of correlative data and associative data, but we do know that infections can trigger autoimmunity, and a few examples from the literature are Epstein-Barr virus as an example of a virus that's associated with thyroid dysfunction. Bacteria, there's Yersinia and Borrelia. And protozoal, we've got blastocystis. So examples from all types of microbes as being associated with thyroid hormone decreased production. Finally, we need to say a word about genetic polymorphisms that can affect thyroid hormone production. Stay tuned to the literature here, of course, too. This list is unabridged, but this is a list of some of the SNPs that will cause lower thyroid hormone production. Okay, next chunk of content. We're going to move away from production now to transport, conversion, sensitivity, detox, and metabolism. So for the thyroid, in terms of putting this together with the whole HPA-TG axis, with the thyroid, what's most important is being able to use your therapeutic interventions for improving production and conversion. Less important would be sensitivity, and probably the least important, detoxification, metabolism. Unlike what you'll experience later in the course with estrogen, where detoxification and metabolism of that hormone are one of the prime ways of intervening. So with the thyroid, we focus a lot on production and conversion. So the transport here, think about transport and especially underlined conversion. Nutrients, food first. Nutrients that improve the conversion of T4 to T3, selenium and zinc. You now know how to do food first on Monday. Patient eats these foods, better thyroid function if they're having trouble converting, or if they're in an environmental condition in which their conversion is impaired. You've just improved their thyroid function. No labs, no supplements. Okay, now this list again. Some of the things on this list will impair conversion of T4 to T3, and some will in some of these environmental conditions, the thyroid gland will appropriately alter its conversion from, instead of going from T4 to T3, it'll go from T4 to reverse T3 appropriately. Which is which? We believe from the evidence thus far, these are the conditions in which the conversion is impaired. Infections may be an exception there, but toxins, liver, kidney dysfunction, certain medications, that impairs the conversion of T4 to T3. In the other conditions, in the other environmental conditions, stress, trauma, low-calorie diet, the thyroid is appropriately altering itself. In those conditions, it may be beneficial to produce reverse T3 rather than to convert to the active hormone. Okay? This is important with the fasting intervals, the calorie-restricted diets that we are now recommending. We don't have the data yet, but we can imagine our patients with low thyroid function being encouraged to go on a low-calorie or a fasting interval diet might affect their thyroid function. So we have to get more data on that, get more literature, and be cautious about that in our clinical recommendations. All right, if we focus on toxins as affecting thyroid hormone conversion now, a toxin to think about, let's shift away from environmental toxins and just focus on iatrogenic toxins, medications that block the conversion of T4 to T3. They block the deiodinase enzymes D1 and D2, and I'll bet some of us are prescribing these. Beta blockers, birth control pills, estrogen and proton pump inhibitors. We're blocking thyroid function. So is there a way we can get around those medications or lower their doses? You can improve your patient's thyroid function just by doing that. Reassess the med list. Work with your pharmacist. What about inflammation? Does inflammation affect thyroid function? Yes. Do all 8 of these environmental domains contribute to inflammation? Yes. Do you know how to help your patients reduce the influence of these domains now? You can do this on Monday, okay? Because any lifestyle intervention that you help your patient make will lower inflammation levels. No cost, no lab, no supplement. You've just improved thyroid function if you can get your patient to engage in any of those lifestyle factors. But how does inflammation do it? Very similar to how stress does it. There's a few intervening cytokines and interleukins and things like TNF and IL-10, but the end result is the same. It's increased cortisol affecting the conversion of T4 to T3. Okay, let's move to sensitivity now. There are ways to affect sensitivity to thyroid hormone. There's 2 nutrients, vitamin A and zinc, and there's exercise, movement. Where else does exercise sensitize? What else does exercise sensitize? Insulin, everybody says, right. So movement is the great sensitizer of the hormones, thyroid and insulin. And what we have to be cautious of with movement in the thyroid conditions is overexertion. Yoga, Tai Chi, those have evidence to back them up. Moderate exercise. And it's often because, as we know, patients with thyroid function often have preceding what dysfunction? Adrenal, that we've just learned about. And this is the kind of movement and exercise that benefits adrenal function as well. So the theme is similar with adrenal and thyroid. Exercise that is not overexertion. And of course, you're going to consider those food groups that give the zinc and the vitamin A to help the sensitivity at the cellular, nuclear, mitochondrial levels. Detoxification, probably the least leverageable therapeutically of the PTSD for the thyroid realm. You should know, especially for getting into the advanced practice module where we talk about T4 and T3 supplementation. T4 has a half-life of about a week, T3 1 to 2 days. You need healthy liver, gallbladder, biliary function, and intestinal function in order to eliminate well. Very basic principle, but we're not going to dwell on this as much. When you get to the estrogen, as I said, we dwell on detoxification and metabolism extensively. So this is the environment in which the thyroid is bathed. We're going to help you help your patient with some handouts in the toolkit. You can see these on the slide, but these are the ones you want to hand out on Monday, and you can help your patient understand. You can help your staff understand why you're doing this, and your colleagues, why you're making these kinds of interventions to improve thyroid function in addition to or instead of supplementing with T4. You'll have to make that call based on the clinical need. Okay, so if anybody wants to stand up again, just take a little quick stretch break for 30 seconds while I go through the next slide. We just keep moving here while we think. It's a long morning. Reinforcement. You're not just going to supplement with T4 anymore. You're going to understand that the problem is the patient's environment. And is the gland altering its function, or is it impaired by the environment? And your solution is going to be to address the environment. And as a functional medicine practitioner now, you're going to try to shorten that trajectory, not by just using good population evidence-based medicine, but personalized evidence-based medicine by making personalized functional medicine interventions to either lower that dose of T4 or maybe eliminate it altogether and allow the lifestyle factors and the other food-first interventions to improve the thyroid function and hopefully prevent comorbid conditions from emerging. And you're going to do it in the same way we did it with Helen. Address those 8 environmental domains at this point in your training. If you even want to make a chart template for 8 environmental domains to think about and address for anybody who comes in with low thyroid function, that's a place to get started in your charting. Okay, take a seat now after our brief stretch. We'll move on to our next chunk of content here. Let's address subclinical hypothyroidism and autoimmune antibodies. So again, to reinforce, when we talk about subclinical hypothyroidism, we're talking about a TSH that is above the upper limit of the reference range and a free T4 that is within that reference range. And we will go to the guidelines again. The guidelines say treat when the TSH is above 10. Not just above the reference range, but above 10. It's got to be pretty high. Helen was above that. Based on the guidelines alone, we could restart that levothyroxine, but she didn't want to. If you're below 10, but above the reference range, the guidelines say it's uncertain who benefits from treatment. And then if you're below 4.5, very little evidence to support treatment. What's treatment in the guidelines, though? Treatment is T4 supplementation. What are we learning now? How to address the thyroid by improving its function without the treatment. So we want to follow the guidelines as they pertain to treatment with T4. We can go beyond that with personalized evidence-based medicine. We can understand what's affecting the function of the patient's thyroid and make those interventions. The guidelines go on to say, here's the dosage of T4 that you should use. It's a lower dosage. Make further adjustments according to the TSH. Okay. Here's Cochrane review data. What's important here is that levothyroxine replacement does not appear to improve clinical outcomes in patients with subclinical hypothyroidism. Why would that be? Think and equate clinical outcomes with emergence of comorbid conditions. By giving T4, have we prevented the emergence of comorbid conditions? No. But if you make your functional medicine interventions, are you addressing underlying causes of those other complications? Much better chance that this type of treatment is going to get good clinical outcomes in your patients. Do we need trials? Of course. But we have the scientific plausibility and we have all the evidence about how lifestyle and behavioral changes work to change physiological functions and outcomes. So we return to our principal slide of 20th and 21st century medicine. We always recommend we follow the guidelines as it pertains to thyroid disease. But we also now want to add to that our personalized evidence-based medicine from what you're learning in this course. Address thyroid dysfunction by addressing the underlying causes, restore function. And levothyroxine replacement is not the only means of addressing thyroid dysfunction. So let's practice good 20th century medicine and let's practice good 21st century medicine. Depicted in this slide, which is hopefully now becoming familiar to you, personalized evidence-based medicine. Every condition, chronic condition, non-communicable illness, has multiple underlying contributors and causes. Different combinations in different patients, even though they have the same disease. Our job as functional medicine doctors is to discern which of those causes are present in which patient and target the interventions according to that cluster of causes for that patient. And then we know that any one of those imbalances or underlying causes is also contributing to the development of other diseases which are currently latent and silent, but will emerge if we do nothing other than give T4 replacement. And Helen has already asked us, as will many of your patients, is T4 the only way to go? It just doesn't seem to help me. I'd like to do something else, and I don't have a lot of money. I can't afford this. So, keeping on our theme of autoimmunity, when should anti-thyroid antibodies be used? Let's go to the guidelines. 3 situations clinically from the guidelines. Subclinical hypothyroidism, that's a green light for testing antibodies. Nodular thyroid disease and recurrent miscarriage. Green light, green light, green light. Test for autoimmune antibodies. This is the most commonly used algorithm for testing antibodies. TSH between 5 and 10, you're certainly justified. If either you have antibodies positive or symptoms present at that point, therapy may be considered. And again, remember, therapy is only T4. If you don't have antibodies, does that prevent you from making the lifestyle changes and the behavioral changes that we know improve thyroid function? Absolutely not. And when you do detect antibodies, what 3 domains do you want to pay special attention to? Assimilation, defense and repair, and biotransformation and elimination, because those 3 contain 3 of the triggers of autoimmunity. So if you've got thyroid antibodies, think about toxins, food antigens, and infections. Next chunk of content, the TSH reference range. If we're going to use this as the sole test, we want to be sure that that reference range is accurate. And there's some data that will show you to question whether that reference range is accurate. Think about, is it really a bell-shaped curve? Is the upper limit too high? Is the curve itself too wide? And does it mean that sometimes a TSH test can be normal, and yet you still need to address the patient's thyroid function because maybe it's not optimal for them? How would you explain that to your patient? Your test is normal, but we still probably should do these things. Okay, so this gets at our 4th performance objective. If this is a spectrum and not a binary, either you have hypothyroidism or you don't, how do we think about thyroid testing in addition to TSH? Well, we know from euthyroid 6 syndrome, now called non-thyroidal illness syndrome, that TSH can be normal and thyroid function is not. Intensive care unit, don't address or assess thyroid function at that point. We know the TSH might be normal and T4 and the T3 are not. And why is this? It's because the reverse T3 is increased when a patient's in the intensive care unit or has a severe infection. But does this only happen in the intensive care unit and with severe infections? That's an environmental input. Does it happen with other environmental conditions? Function follows environment. Is the function of the thyroid gland not impaired by other lesser environmental insults? Might that also induce conversion to reverse T3 as opposed to T3? And might the TSH be normal even though we're converting to reverse T3? Okay, so let's define our terms here. What we're looking at now is the TSH range of 0.3 to 4. That's currently the lab reference range. If that's the reference range, and if it is a bell-shaped curve, where's the mean? It would be 2.15 if you do the math. What does ethnicity data tell us in large population samples about the true mean of the TSH? Much lower than 2.15. In whites, it's a little above 1.5. In non-whites, it's below that. So it's 1.4 to 1.5 probably in this country. I'm a fan of Shakespeare, so I want to bring in my Shakespearean characters here. Quick quiz, whose TSH level is higher? The pale Northern European Hamlet or the darker Northern African Othello? Whose TSH was higher? Probably Hamlet, right? Being of Northern European extraction, those TSHs are higher. We're going to revisit Hamlet and Othello in a moment. But we see from here, ethnicity data shows us that the bell-shaped curve is a little bit problematic. And if 1.5 is closer to the true mean, wouldn't we expect the bell-shaped curve to extend from about 0 to 3? And yet it extends from 0.3 to 4. So is the bell-shaped curve off-center? Is it a bell-shaped curve? Is there a crack in this theory? So some clever investigators went back and looked at the original blood samples from the population from whom this data was derived. And they tested it for thyroid antibodies, and they looked closer at the charts. And they removed people who had goiter, and they removed people who had strong family histories of hypothyroidism. And they found that the upper limit of normal should not be 4. It should be between 2.5 and 3. Published in JAMA, 2003. Pretty good journal. The year before that, the American Academy of Clinical Biochemistry publishes laboratory guidelines, concluded that you may be in early thyroid failure if your TSH is above 2.5. Same year, 2002, the AACE, one of the greatest specialty organizations in the endocrine field, concluded TSH upper limit was 3.04. 2005, the American Thyroid Association in a point-counterpoint series argued that it could be argued that the upper limit should not be above 2.5. 2008 in Europe, they developed a risk score to predict your future risk of hypothyroidism. You begin accruing points as soon as your TSH rises above 2. More recently, if you're addressing depression, this came from BMC. TSH above 2.5 can be problematic if you're addressing a patient with depression. So there's some support in the evidence and from some pretty good specialty organizations and journals that the TSH upper limit might be a little too high. Now, what about personalized evidence-based medicine? Are population-based reference ranges applicable to individuals, or are individual ranges more narrow? This gets into a little bit of a complex concept called the intra to the inter-individual variability of a laboratory analyte. And if we think about TSH, what's the intra to inter-individual variability? This is expressed as a decimal, and with TSH, with that slide showed, with TSH, T4, and T3, it's pretty low. How low is it? With TSH, it's 0.36. So what this means when you're thinking about a bell-shaped curve reference range is, that's the population range. For an individual, their normal range is 36% of the width of the population range. Put in another way, 64% of the population-based reference range is outside the normal for an individual. It's worth saying again. 64% of the population-based reference range for TSH is outside the normal or optimal for an individual. If you do the numbers, what would that mean in absolute milli-units on the lab test? It would be 0.75 milliunits per liter. So if we go back to our mean of 1.5 from the ethnicity data, the optimal range for most individuals is going to be about 0.75 to 2.25 based on those publications and that evidence. So some pretty compelling evidence that we have a TSH reference range that may be too high for individuals and an entire population-based reference range that may be too wide.